Thank you very much, Laurent, for the kind introduction, and I would like, on behalf of the panel, to thank EASL for giving us the opportunity of providing a lot of work, I must say, but something we consider a service to the community by writing and updating regularly these EASL recommendations on treatment of hepatitis C. It's an honor to do that. I think also it's something extremely useful. And I hope you will enjoy the presentations today and that this will start an ongoing discussion on treatment of hepatitis C and your practice. So the way we're going to structure this evening session is the following. I will give you a brief presentation, summary presentation of the recommendations on treatment of hepatitis C 2016, which some of you may have had time to read already, but those who did not will see what is new. Then we'll have a discussion with the panel members on specific issues that were obviously the focus of our difficult discussions, and they will give you more information, and then we'll finish with a Q&A session. Obviously, I welcome you all, but I also want to welcome the people who are just behind you there, who are following this session on the live stream. We have cameras here, and everything is recorded, and people are watching on internet, so they're also very welcome. So there are more people in this room than you can eventually think. So these are recommendations on treatment of hepatitis C 2016. As you know, Europe is diverse. We have different countries, different cultures, different medical systems, different reimbursement systems, and EASL has committed itself to provide recommendations of treatment are based on the science and are obviously applicable in every country. We're making proposals, we're making suggestions. Every country can adapt the recommendation to its own system, to drugs that are available, to the reimbursement strategy in the country. But we do not serve only Europe and the many European countries. I was 2 weeks ago traveling in Asia, Singapore, Hong Kong, Taiwan. And I can tell you that in that area as well, like in many other areas of the world, the EASL recommendations were eagerly awaited. And we know that we're also being extremely helpful in guiding, helping people in these countries to treat their patients. So we hope that these guidelines are really the international guidelines and are helpful to many people all over the world. So I would like to thank the panel. You have a list here, and you can see them here sitting. I know we have a gender issue. We'll have to solve this one day. The panel is made of Alessio Agemo, David Back, Jeff Ducheco, Xavier Forns, Franco Negro is representing the EASL Governing Board, Massimo Porti, and Christophe Sarrazin. Christophe could not join us tonight. And these are the disclosures of conflicts of interest of the panel members. I would like to start this summary of the guidelines by reminding you the goal of therapy. The goal of therapy is to cure HCV infection, to prevent hepatic cirrhosis, decompensation of cirrhosis, hepatocellular carcinoma, severe extrahepatic manifestations, and death. The endpoint of therapy has not changed. It is undetectable HCV RNA in a sensitive assay with a lower limit of detection of 15 IU per ml or less, 12 weeks SVR12, and or 24 weeks SVR24 after the end of treatment. But something new here is that undetectable HCV core antigen 12 weeks and or 24 weeks after the end of treatment is an alternative endpoint of therapy in patients with detectable HCV core antigen prior to therapy. And this is for people who do not have access to HCV RNA assays or for whom HCV RNA assays are not affordable. Therefore, it's possible to monitor, to diagnose and monitor HCV infection by means of core antigen. And the reason is summarized here. You can see here one of several studies showing the excellent correlation between the HCV RNA level here and the HCV core antigen level, meaning that the core antigen level is a good surrogate marker of HCV replication, less sensitive than HCV RNA detection. The analytical sensitivity of the core antigen assay is approximately 500 to 3,000 HCV RNA IU per ml. There are rare false negatives of core antigen, but overall it is an acceptable marker, and we hope that the use of core antigen instead of HCV RNA will help improve access to care and make that more patients will be treated in the future. What are the treatment indications? I believe EASL was the first international association to say that every patient who is HCV infected has the right to be treated. And the recommendation this year is that all treatment-naive and treatment-experienced patients with compensated or decompensated chronic liver disease due to HCV must be considered to therapy In other words, EASL supports universal access to treatment. I think it's a very important step forward. That being said, we know that there are many patients with HIV infection and that not everybody will be able to be treated immediately. Therefore, there is a list of patients that we believe should be treated without delay, and these patients include patients with significant fibrosis or cirrhosis, including METAVIR score F2, F3, and F4, including patients with decompensated cirrhosis. Also patients with clinically significant extrahepatic manifestation. Franco Negro will speak about this. HIV recurrence after liver transplantation, and also all individuals who are at risk of transmitting HCV, including active injection drug users, men who have sex with men with high-risk sexual practices, women of childbearing age who wish to get pregnant, hemodialysis patients, and incarcerated individuals. What are the therapies that are currently available in Europe? 3 drugs were approved in 2014, are still on the market as individual drugs. They include sofosbuvir, active against all genotypes, imipravir, active against genotype 1 and 4, and declatasvir, active against all genotypes. The following year, we had several fixed-dose combinations that were approved. The first one is sofosbuvir and ledipasvir, active against genotypes 1, 4, 5, and 6. And the second one is a fixed-dose combination of umbitazvir and ritonavir boosted paritaprevir, which is active against genotype 1, and the sabuvir that can be used together with this fixed-dose combination and is active against genotype 1 only. Finally, this year, a few weeks ago, 2 new fixed-dose combinations were approved for use in Europe. Sofosbuvir velpatasvir, which is pan-genotypic, active against all genotypes, and the combination of grazoprevir and elbasvir, which is active against genotypes 1 and 4. This is what we have, and this is what we use to make the recommendations. I would like to remind you that several of these drugs have drug-drug interactions with a number of other drugs, and everything is very nicely summarized in the website of the University of Liverpool, which has become a tool that we all use to treat our patients. This information is summarized in the guidelines document in the form of tables that have been put together by David Back and his team. David will speak a little bit about it. I think these tables are very helpful to give you a good idea of what happens. I took the example of drug-drug interactions with HIV antiretroviral drugs, which are listed here. You can see, for instance, that sofosbuvir can be used with any of these drugs, but the combination of sofosbuvir, velpatasvir, or the 3D or grazoprevir, elbasvir has some contraindications for use with several drugs, and I think this resource is extremely important. Another example is that cardiovascular drugs with a different table, and you can see here the amiodarone issue that was raised last year when we presented the recommendations in 2015 with contraindications with virtually all drugs for hepatitis C and other contraindications or other dose adjustments needed. David will speak about this in detail here, and I want to reiterate our gratitude for all the work that's been done by the University of Liverpool to help us treat patients well without always understanding exactly what the interaction is, but getting the right information to make the right decision. So a few general considerations about the EASL recommendation before we go into detail for the different genotypes and what is new in the recommendations. And the first thing is that this year we consider that interferon-free regimens are the best options in HIV mono-infected and in HIV co-infected patients without cirrhosis or with compensated Child-Pugh cirrhosis, because of their biological efficacy, ease of use, and tolerability. And for the first time in the history of EASL, we have interferon-free guidelines. There is no interferon regimen recommended. Doesn't mean this is forbidden. If this is the only thing you have in your country or the only thing you can afford, that's fine. You can use the previous guidelines, but the recommendation for the best of science, the best we can do for our patients, is currently interferon-free. And the same interferon-free treatment regimens can be used in HIV co-infected patients as in patients without HIV infection, because the virological results of therapy are identical in both populations. This slide summarizes the options we consider as equally valuable for the different genotypes. One thing which is different from the previous guidelines is that the combination of sofosbuvir plus ribavirin is no longer considered as a valuable option. It was never for genotype 1, 4, 5, or 6. But we consider that it is suboptimal for genotype 2 and 3 and should not be used. We currently have 5 options for genotype 1, combination of sofosbuvir and ledipasvir with or without ribavirin, sofosbuvir, velpatasvir, the 3D combination, grazoprevir, albasvir, or sofosbuvir plus declatasvir. Based on real-world data, the combination of sofosbuvir plus imipravir was considered suboptimal compared to the others. Again, if this is the only thing you have, it's a reasonable option, but if you have other choices, they are better. For genotype 2 and 3, we have only 2 options available, the combination of sofosbuvir, velpatasvir, and the combination of sofosbuvir plus declatasvir, which is a limited choice, and we may come back on this. More options for genotype 4, sofosbuvir, ledipasvir, sofosbuvir, velpatasvir, 2D combination, grazoprevir, albasvir, sofosbuvir, declatasvir, and sofosbuvir, imipravir. And for genotype 5 and 6, we can use sofosbuvir plus any of the NS5A inhibitors, declatasvir, ledipasvir, or velpatasvir. So a very important point, because there was some misunderstanding, I think, in the past recommendations, is that for the panel, these options are considered equivalent to each other for a given genotype. Their order of presentation does not indicate any superiority or preference unless specified so. It's not because an option is option 1 and it is better than option 2. It's a very important point. We put them at the same level. There are other considerations that will guide your choice, but for us they are the same. And by convention, the way we present them is that the combination regimens listed start with a fixed dose single pill combination. We start with sofosbuvir base, followed by sofosbuvir free, and followed by combination of sofosbuvir with another drug in a different pill. But again, this is a flat presentation. There are no preference. The ones we think are not as good as the others, we just remove them from our recommendations. So there are several characteristics that inform treatment option selection. Still, we were expecting that we would be able to simplify the guidelines. The initial document last time was 140 pages. This time it is 170 pages. Unfortunately, it becomes more and more complicated. And you know that the indication is based on a number of pre-treatment parameters, the HCV genotype and subtype, the severity of liver disease, the existence of comorbidities, the PK profile of the drugs, drug-drug interactions, and prior treatment experience. And this, at the end, makes it relatively complicated. So let's focus on what is new for the different genotypes. This is the indication for genotype 1. Be reassured I will not go into detail in these different indications. You have the list of the 5 options. Here, no cirrhosis, compensated cirrhosis, treatment-naive, treatment experience. Everything is detailed in the document. But I would like to emphasize 4 specific points. First one is 8-week treatment in patients who have genotype 1A infection and receive sofosbuvir and ledipasvir. The second point is the fact that what is new in the guidelines is that we're now recommending that sofosbuvir and ledipasvir be used with ribavirin in treatment-experienced patients with or without cirrhosis, but no longer ribavirin in treatment-naive patients with compensated cirrhosis. The third point is sofosbuvir velpatasvir, a new treatment which is recommended for 12 weeks without ribavirin in genotype 1A patients. And finally, the combination of grazoprevir and albasvir, which is recommended for 12 weeks without ribavirin if the HCV RNA is below 800,000 IU per ml, or 16 weeks with ribavirin if the HCV RNA level is above 800,000 IU per ml, with the specification, and we'll come back on this, that if these patients have RAS testing, HCV-resistant testing, only those patients with detectable NS5A RASes should have the longer treatment with ribavirin. What data support this? First of all, the 8 weeks treatment for patients who are treatment naive without cirrhosis and less than 6 million IU per ml with sofosbuvir and ledipasvir. These are the results of the ION trial that suggested this was a good option with 8 weeks. And these are several real-world studies that confirmed overall the very good results with this combination. So we can now accept that patients with genotype 1 who have a low viral load and no cirrhosis can be treated 8 weeks with this regimen. This slide illustrates a change in the recommendation for sofosbuvir and ledipasvir with patients who are infected with genotype 1A. You can see here patients with detectable NS5A RASes in red at baseline and patients without NS5A RASes at baseline in green. In patients who are treatment naive without cirrhosis, there is no difference in SVR, But to our surprise, when this data was presented at the EASL meeting, we saw an almost 10% difference based on the presence of NS5A RASes between patients who had detectable RASes at baseline and those who did not have detectable RASes at baseline. And this supports the recommendation that if you do not have access to resistant testing, you should treat treatment-experienced patients who have no cirrhosis with ribavirin for 12 weeks, whereas if you have access to NS5A RAS testing, only those patients who are treatment-experienced and have NS5A RASes should receive ribavirin. And the same applies to patients with cirrhosis. Treatment-naive patients, virtually no difference, and a 10% difference almost for treatment-experienced patients with cirrhosis. This is the basis for this recommendation. Other recommendation to use sofosbuvir and velpatasvir for 12 weeks in patients infected with genotype 1, and this is based on the results of the Astral-1 study in a very large number of patients with very high SVR rates with this regimen. And finally, what supports the recommendation based on the HEV-RNA level in patients receiving grazoprevir-elbasvir. This is this set of data, which you may not have seen presented this way, and I would like to thank Merck for providing the panel with this sub-analysis on our request. And this shows different things which are really interesting. Patients without NS5A RASes are in green. Patients with detectable NS5A RASes are in red. Where here with the treatment-naive patients, you see that in patients who have less than 800,000 IU per ml, it doesn't make any difference to have or not to have NS5A RASes. These patients have very high SVR rates with 12 weeks of grazoprevir-elbasvir, and that's the right indication. In contrast, in patients who have more than 800,000 IU per ml, the SVR rate without elbasvir RASes is 97%, whereas it is 52% only when NS5A RASes are present. And this means that either you don't have access to RAS testing, and all patients with more than 800,000 IU per ml should be treated 16 weeks with ribavirin, or you have access to RAS testing, and you can treat only those patients with more than 800,000 IU per ml and NS5A RASes detectable at baseline with 16 weeks plus ribavirin. And the same applies to the group of treatment-experienced patients, high SVR rate with a low viral load, high SVR rate with a high viral load without NS5A RASes, and low SVR rate with NS5A RASes. Again, no access. All these groups should be treated with a longer duration with ribavirin. If you have access to resistant testing, treat only those patients who have RASes plus the high viral load. What about genotype 1b? Nothing really very exciting or interesting. I just want to emphasize the fact that we now have an indication for 8 weeks treatment with a 3D combination of abemaciclib, paritaprevir, and dasapuvir. And this was based on the Garnet study that will be presented tomorrow, I think, at the EASL special conference. It's a study in genotype 1b, treatment-naive patients without cirrhosis, F0, F3. These patients were treated for 8 weeks without ribavirin with the 3D regimen, and the SVR rate was 97%. SVR was 13 out of 15 in F3 patients, and therefore we felt that we could include this short duration for genotype 1b patients receiving the 3D combination. What about genotype 2? Genotype 2 options, nothing really exciting, except that we now have a very good treatment, which we didn't have before with sofosbuvir plus velpatasvir, and these are the results of the Astral-2 study. They confirmed that sofosbuvir plus ribavirin here in green is suboptimal in various groups, and confirmed that sofosbuvir plus velpatasvir is a good treatment with very high SVR rates in this genotype, 99% in treatment-naive without cirrhosis, 100% in treatment-naive cirrhotics, and all patients who were treatment-experienced also achieved SVR with sofosbuvir, velpatasvir, 12 weeks without ribavirin, and this justifies the indication. Genotype 3. Genotype 3 used to be the most difficult to cure genotype, and it remains probably a little bit more difficult to cure than other genotypes. As I said before, we currently have 2 options only for genotype 3, sofosbuvir, velpatasvir, and sofosbuvir plus declatasvir. And after discussion, the panel decided that only treatment-naive patients without cirrhosis would receive the combinations without ribavirin, whereas treatment-experienced patients without cirrhosis and patients with cirrhosis, treatment-naive and treatment-experienced, should be treated for 12 weeks with ribavirin. This is based on the results of the Astral-3 trial. You can see here again that sofosbuvir ribavirin in green 24 weeks is suboptimal, too low SVR rates. Sofosbuvir plus velpatasvir 12 weeks yielded an SVR rate of 98% in patients who were treatment naive without cirrhosis, but the other patients had lower SVR rates, 93% in cirrhotic treatment naives, 91 and 89 in the non-cirrhotic and cirrhotic patients who were treatment experienced respectively. And if you look carefully at which patients did not respond, they are essentially patients with NS5A resistance at baseline, and more specifically, the Y93H substitution. So again, there are two different options. Number one, you do not have access to resistant testing. You can treat patients very well. You can optimize treatment, just treat with 12 weeks plus ribavirin, the patients who are treatment experienced, non-cirrhotic and all cirrhotic patients. If you have access to resistant testing, just add ribavirin for the patients who have the Y93H substitution present at baseline. The other patients do not need ribavirin. And I think if you do this, the SVR rates with genotype 3 patients will be extremely high. Many options for genotype 4. Again, I will focus on sofosbuvir, velpatasvir, and the indication for grazoprevir, elbasvir, which are the two new regimens available. Astral 1 told us that based on a relatively high number of patients, 100% of genotype 4 patients could achieve SVR with 12 weeks of sofosbuvir, velpatasvir. And grazoprevir, elbasvir, this slide illustrates the reasons why we made the recommendation we made. Treatment-naive patients have very high SVR rates with no ribavirin and grazoprevir, elbasvir alone. In treatment-experienced patients, things are slightly different, and the highest SVR rate was achieved with ribavirin and 16 weeks. We don't have results with the different viral loads, but by analogy to genotype 1, we decided to make the same recommendation based on an HCV-RNA level above or below 800,000 IU per ml. There is no information as to the role of NS5A RASes in this group of genotype 4 patients. Finally, genotype 5 and 6 have the new treatment with sofosbuvir and velpatasvir, and Astral 1 showed that the results were excellent with very high SVR rates. Summary of the utility of HCV-resistant testing, which is a very important point prior to first-line therapy. The guidelines are pretty straightforward. What we say is the following. Systematic testing for HCV resistance prior to treatment is not recommended. Indeed, this obligation would seriously limit access to care, and treatment regimens can be optimized without this information. I hope I've been able to show you that this is the case. If you slightly overtreat some patients, more patients will receive ribavirin or will have slightly longer treatment duration, but you will achieve very high SVR rates. But if you have access, if you have easy access to a good test, it has to be reliable. You must be sure that the test is of good quality, that assesses HCV resistant to NS5A inhibitors, spanning amino acids 24 to 93. Then you can use these results to guide your decisions, and this is explained in detail in the document. The test should be based on population sequencing, reporting RASes as present or absent, or deep sequencing with a cutoff of 15%, and only the RASes that are present as more than 15% of the whole population should be taken into consideration. So if we summarize, there are two ways to treat your patients. Number one, I think this is for the majority of treating physicians. The test is not available, you don't have it, or it's not affordable. No problem, you can treat your patient very well. Just need to optimize therapy to avoid treatment failure. Add ribavirin for genotype 1A, 4, 5, or 6 in patients who are treatment experienced with sofosbuvir, ledipasvir, sofosbuvir, declatasvir, or sofosbuvir, cimeprevir. With sofosbuvir, velpatasvir, add ribavirin in genotype 3 treatment experienced patients and cirrhotics. And for grazoprevir, elbasvir, use 16 weeks with ribavirin genotype 1A. If you do this, you will have very high SVR rates, very low rates of treatment failure without any NS5A resistant testing. Now, if you're in a place where you can do resistant testing, the test is available, reliable, interpretable, understandable, which is many conditions, not fulfilled everywhere. Then the presence of NS5A RASes that confer high-level resistance will tell you that only that population will need to add ribavirin and or increase treatment duration in those patients. But I think it's very simple, straightforward, and we're trying to cover all settings and all what you can find in your current environment. I will finish with some special populations which are important. The first one are the patients who have decompensated cirrhosis awaiting liver transplantation. And the panel decided that patients with decompensated cirrhosis without HCC awaiting liver transplantation with a MELD score below 18 to 20, we couldn't find an agreement on 18 or 20, so it's around 18 to 20. These patients can be treated prior to liver transplantation, probably with a benefit. In contrast, and I think this is new in the guidelines, patients with decompensated cirrhosis without HCC awaiting liver transplantation who have a MELD score above 18 to 20 should be transplanted first without antiviral treatment, and HIV infection should be treated after liver transplantation. Obviously, in these patients, if the waiting time on the transplant exceeds 6 months in your place where you work, the patients can be treated before transplantation. But if it's less than 6 months, just the most severe patient, transplant them first. They'll benefit from transplantation, treat them after transplantation. And this is based, obviously, on the results of the SOLAR-1 trial, which showed very high SVR rates in patients with decompensated cirrhosis, approximately 85 to 90%. But this is also based on the fact that we realize that the proportion of patients who improve their MELD score being treated with decompensated cirrhosis is not that impressive. It's a small third of patients who improve their MELD score, a big third that remains with no change, and a small third that aggravates infection. The patients who benefit more from treatment are the patients who are the least severe, whereas the other patients certainly are able to cure HCV, but this does not appear to have a major impact on their outcome, clinical outcome, events, death, and therefore these patients should be transplanted. And this is, I think, also supported by these 3 studies that were recently presented, showing in the French cohort, in the European multi-center cohort, and in the Spanish cohort, that the proportion of patients who are treated before transplantation with very severe disease and are delisted from transplantation is relatively low, 18, 20, 16%, and improvement is also not very frequent, 16, 13, 12, based on clinical endpoints. What about post-liver transplant recurrence? This is a very ideal situation. These patients should be considered for therapy, and treatment should be initiated early after liver transplantation, ideally as early as possible when the patient is stabilized, generally after the first 3 months post-transplant, because the SVR12 rates diminish in patients with advanced post-transplant liver disease. And this is illustrated here again by the SOLAR-1 study, which showed that if you treat patients in the post-transplant setting before they have advanced cirrhosis, you will have very high SVR rates, nearly 100%, so it's no harm transplanting a patient, waiting post-transplant to treat the patient. If you treat the patient early enough before he has severe liver disease, you will have excellent results. You will have cured the liver, and you will have cured the infection. Patients with decompensated cirrhosis without an indication for liver transplantation, obviously these patients, if they are not on the waiting list for liver transplantation, do not have concomitant comorbidities that could impact their survival, should be treated urgently. You will try to improve them because you have nothing other to offer. Protease inhibitors should not be used in patients with Child-Pugh-B and are contraindicated in patients with Child-Pugh-C, and these patients should be assessed very frequently, clinically, and biologically. There are several special groups that are addressed in the recommendations. I will not discuss all of them. You have the document. It's not useful. We speak about HBV co-infection, immune complex-mediated manifestation of chronic hepatitis C, and several comorbidities, including renal impairment, non-hepatic cellular organ transplant recipients, PWIDs, hemoglobinopathies, and bleeding disorders. I'll focus only on the renal impaired patients because these patients have been problematic in the past, and we have tried to find useful recommendations and reasonable recommendations that make it safe as possible. In patients who have a glomerular filtration rate above 30, it is recommended to treat according to general recommendation. There are no issues with the drugs we have, and you can treat according to what I said before, based on the genotype, the severity of liver disease, etc. The problem is for patients who have a reduced glomerular filtration rate below 30, or who have end-stage renal disease and are on hemodialysis. In these patients, sofosbuvir should be used with caution because no dose recommendation can be given based on the data we have. So it's relatively easy for genotype 1 and 4 patients. These patients have access to 2 regimens that are perfectly safe in patients with advanced renal disease. This can be either ombitesvir, paritaprevir, and zabuvir, or grazoprevir, elbesvir. The problem for other genotypes For the other genotypes, we only have sofosbuvir-based regimens. And if the patients need to be treated urgently, you have no other option than using a sofosbuvir-based regimen. So what we recommend is to use these sofosbuvir-based regimens with caution and have a close monitoring of the renal function and stop treatment if the renal function aggravates. This is based on the following results showing that in patients with advanced renal disease, the concentrations of sofosbuvir and its renal excreted metabolite 007 are very high, much higher than in patients with a normal or mildly impaired renal function. And the good results of the combination I mentioned in patients with chronic kidney disease and an eGFR less than 30, 90% SVR rate here in this combination of abemaciclib, paritaprevir, and the sabuvir in the RUBY-1 trial, and the CSURFER trial with grazoprevir-elbasvir shows also that the combination of grazoprevir-elbasvir is efficacious, and safety data indicate that there is no problem in patients with chronic kidney disease. Another point also is that recent results showed 100% SVR rates after renal transplantations, and in patients who have an indication for renal transplantation, it's very reasonable to wait until renal transplantation has happened and to treat them after transplantation with the expectation that the SVR rates will be extremely high. Two last points I want to discuss: retreatment and acute hepatitis. Retreatment, in fact, there are two groups of patients. Patients that we could consider as relatively easy to retreat, and other patients who are difficult to retreat. Let's focus on the patients who are easy to retreat. These are the patients who have never been exposed to an NS5A inhibitor. They have never received a cladesvir or ledipasvir or ambitesvir or velpatasvir or elbasvir. Never an NS5A inhibitor. There are four groups of patients. PEG interferon plus ribavirin failures. This is what we call treatment-experienced patients, a general recommendation. They are easy to retreat. If you follow the recommendation, you will have very high SVR rates. There are another group of patients, the ones who have been exposed to PEG interferon, ribavirin, and a protease inhibitor. These patients should be retreated with sofosbuvir plus an NS5A inhibitor, 12 weeks with ribavirin. There are different studies that show that the SVR rates will be extremely high. Third population, patients who have been exposed to sofosbuvir as only DAA, sofosbuvir alone, or sofosbuvir plus ribavirin, or PEG interferon ribavirin sofosbuvir. Sofosbuvir does not select resistant viruses, so they are relatively easy to retreat as well. It is recommended to treat them according to the general recommendations. 24 weeks for F3, F4 patients, they are generally a little bit more difficult to retreat because if they fail with these regimens, it's that they have something which makes them more likely to respond, and with ribavirin, but should be okay. And the last group of relatively easy to retreat patients are the sofosbuvir cimeprevir failures, which can be retreated with sofosbuvir plus an NS5A inhibitor 12 weeks or 24 weeks if they have F3 or F4 cirrhosis with ribavirin. Very clearly, the problem we're facing now is the patients who have been exposed to an NS5A inhibitor and failed on that regimen. And if you look at the recommendation, virtually all interferon-free regimens contain an NS5A inhibitor. This is one more reason to follow the recommendations to optimize therapy and achieve high SVR rates from the beginning. But some patients were not lucky enough to achieve SVR. They come back with NS5A resistant substitutions. You do not need to look for them with a resistant test to know that they have selected viruses that are resistant to NS5A. And therefore, we don't have many options, and the recommendation we're making is the following. The retreatment regimen should contain sofosbuvir, always, because of the high barrier to resistance. 2 or 3 other DAAs, if possible, with no cross-resistance with the ones that have been administered, but it's not always possible, plus ribavirin. Treatment duration should be 12 or 24 weeks, certainly 24 weeks for patients who have advanced fibrosis or cirrhosis. And I would like to insist on the fact that close monitoring is required because these regimens we are recommending are off-label combinations, so you have to check whether you can use them. They are expensive combinations, and we have very limited safety data for this, but the experience of some members of the panel are that only these kind of combinations can work, and even these combinations do not always work when you retreat patients who have selected NS5A resistant viruses. Again, another reason to be efficient from the beginning and optimize therapy from the very beginning. So how does this translate in clinical practice? Genotype 1 or 4 can be retreated with sofosbuvir plus 3D. It's 4 drugs together, sofosbuvir, abitavir, paritaprevir, ritonavir, dasabuvir, 5 drugs, plus ribavirin, 6 drugs. Not a lot of safety data, you have to do that very carefully, but it looks like a decent option. Another option is sofosbuvir plus grazoprevir, elbasvir plus ribavirin, and a third option is sofosbuvir, declatazvir plus imipravir plus ribavirin. Be very cautious in patients with F3 or patients with compensated cirrhosis. We had problems in my place with sofosbuvir, declatazvir, imipravir in patients who were compensated cirrhotics but were a little bit borderline. This has to be used with extreme caution, but there is very often no other option for these patients. Unfortunately, we do not have that many drugs for patients infected with genotype 2, 3, 5, or 6. Therefore, the only option is to retreat with sofosbuvir and velpatasvir for 24 weeks with ribavirin. Some patients will fail again, and I'm afraid that in these patients, we do not have much to offer right now, especially the patients with advanced liver disease, but we can also wait for a few months. Alternative therapeutic options will be available next year, and hopefully it will be possible to retreat these patients with the next generation drugs. And just to illustrate this point, I wanted to show you the Quartz-1 study. This is a retreatment study based on a very small number of patients with sofosbuvir plus 3D, 4 or 5 drugs according to the presence of ribavirin or not in a combination, and good results actually, 93% in genotype 1A, no cirrhosis with 12 weeks with ribavirin. All patients with 1A cirrhosis, 24 weeks with ribavirin, and all patients with genotype 1B, 12 weeks without ribavirin. So it's, again, in terms of efficacy, it's a good combination, but be very careful with safety and do this in expert centers and under a very strict control. The very last point I want to address before we move on to the discussion is the treatment of acute hepatitis C. We now have clear interferon-free recommendations, which I think were eagerly awaited. Acute hepatitis C patients should be treated with sofosbuvir plus an NS5A inhibitor. It can be velpatasvir or declatazvir or ledipasvir. Treatment duration should be 8 weeks. It's enough. It's been shown without ribavirin, and you should be able to achieve very high SVR rates. Acute hepatitis C in HIV co-infected patients, or when the patients have an HBRNA level above 1 million IU per ml, should be treated with the same combination regimen, but we recommend that treatment be increased to 12 weeks, just because these patients appeared to be a little bit more difficult to cure. So this is where we are. I think we've come a long way in the treatment of hepatitis C, and I would once again like to thank the panel. I hope you understand the amount of work this represents to put together these guidelines, make them as clear as possible, as useful as possible. Everything can be criticized. We have 1 hour now to discuss, criticize, ask questions. I want to tell you also that there will be a live chat, so I will be checking my cell phone. It's not that I'm boring myself when my friends are speaking. It's just I'm checking the questions people are sending by the live chat on my Twitter address, and we'll try to bring these questions as well. So on this, I would just like to thank you for your attention, and we move on to the rest of the session.